Hi, my name is Leona Ong, and I lead a team that is responsible for skin diseases and the global burden of disease study. Today, I'd like to talk to you about how we make estimates for skin diseases. First, I'd like to talk a little bit about what the global burden of disease studies is, for those of you who may be unaware, what skin diseases, how we capture them within the GBD, what goes into generating these estimates, and then some opportunities for engagement. So, the Global Burden of Disease Study is a worldwide effort to quantify health loss from diseases, injuries, and risk factors, to produce comparable estimates of mortality and disability across every country, age, and sex for every year since 1990. The estimates produced by GBD are comparable, comprehensive, and consistent. GBD is able to do this because of 7 distinct features that are unique to our process. The first is that the GBD is one integrated framework. We have one system where we reconcile the information produced for every cause, risk, age, sex, year, and location. GBD is also iterative. Within every GBD round, we may have developed new methods, we may integrate new processes, we may integrate new information about the disease epidemiology, and we want each round of GBD to reflect the best available knowledge and methods that are available to us. So each round of GBD, we re-estimate the entire historical time series, so all trends stay methodologically consistent within a GBD round. We also provide uncertainty intervals on each estimate that we produce. The information that we use to generate GBD and on our methods and the way that we have thought through our process is available in the protocols, in code, through our publications, and in public results tools. And GBD is not simply an organization that is contained within Seattle, which is where I'm based out of. It is a global public collaboration. And currently, we have over 20,000 collaborators from over 160 countries that contribute local data and expertise. So, skin diseases are not simply one disease. We can think of skin diseases as actually skin assaults, and that sits across many different parts of the GBD cause hierarchy. Most skin diseases sit within this group called skin and subcutaneous diseases. In this left-hand panel, what I'm showing you is a flow chart of the 15 skin diseases that we make available within our GBD estimates. There are a few additional diseases that we also estimate that they are within these larger groupings, but they are not publicly available. However, there are additional skin diseases that people often consider, such as skin cancers. Those can be found under neoplasms. Other diseases like leprosy and leishmaniasis can be found in our neglected tropical diseases. And then skin disorders that are the result of other diseases, such as diabetic foot ulcers, can be found within the larger disease areas that they can be found in. What we see here is that skin and subcutaneous disease grouping that I mentioned earlier is the 9th leading prevalent disease in the world in GB 2023. And here on the right, I'm showing a map of the age standardized prevalence of skin diseases throughout the world in 2023, so you can see the geographic variability. So GBD estimates are made through a very rigorous process. Behind every estimate is a really thoughtful accounting of process through first disease grounding. Within each disease area that we look at within GBD, we understand the pathophysiology of the disease. We understand the elements that make the disease complex to understand, to describe, and document. And we need to understand reasons for knowledge gaps across those demographic dimensions. Here we get a very high-level picture of what this disease is and why is it important and what makes it difficult. Because we know that there can be a lot of conflicting evidence out there in the world, within our experts, within the literature, We also have to have some way of determining what truth is at this moment in time. We determine this by engaging with debates with our experts. We have structured critiques around all dimensions informing knowledge. We push back on our experts, and our experts push back on us. We also evaluate the evidence base and all the literature that is available out there. And through this process, we are able to use that information to query back to our experts and have our experts query back to us on what is reasonable and reasons of why information exists the way it does and what is most likely to be true if there is debate. We are also able to reflect the nuances that can occur when you have diseases that have such different epidemiology across time, across location, and across age. We take these pieces of information and we use it to build our modeling strategy to determine what assumptions we're willing to take and tolerate, to understand the biases that exist within these disease areas and the severity of these diseases. It also helps us understand where we will make estimates. What populations do these diseases occur in? What years maybe they occur in? And we also use this to understand the limitations of the data and our knowledge base for these diseases. It helps us appreciate the nuance and the complexity of our conditions. We are also able to generate the uncertainty around each of our values. This helps us be incredibly transparent about the information that we're providing and what we are unable to provide. We can take this information to also shed light on opportunities for where there are data gaps, for where there should be more effort and energy spent on research priorities, and then how to communicate these results to the wider public. However, for skin diseases, we observe 7 common challenges that makes this process difficult. First, in many regions and in age groups, there is no data. We also identified that there are almost no population-based surveys. For many skin diseases, mild forms that do not go seek care are missed without community sampling. We also know that for many of these skin diseases, that the diagnosis can vary based on the specialty of the provider, and that makes it difficult. We also know that many of these diseases observe a waxing and waning course, and so that makes it difficult to disentangle the difference between new incidence cases versus cases that are just reoccurring. We also know that for many diseases, there are self-treatment options, or there's not necessarily a need to necessarily seek care. And so what that happens is that then those individuals bypass healthcare system reporting opportunities like clinical records. We've also observed that there can be ambiguous case scope. So while we can see literature that use words like itching and eczema, that's part of the diagnostic criteria or that's how they're defining the cases, they don't necessarily represent the disease of interest. Or it's not clear based on the methods what type of disease are actually capturing. We're also aware that there is incredibly heterogeneous epidemiology for many of these diseases. And so the patterns should differ by region and age. But when there's a lack of data, making exceptions across populations can be risky. For each disease area, we appreciate and we understand each of these challenges and the impact that these challenges can have on the estimates and how robust those estimates can be. So we acknowledge and we document and we are transparent about where assumptions are made. So I want to show an example of how that can manifest itself when we look at the data. Here are estimates of psoriasis from 3 insurance claim sources across the world in the United States, Poland, and the Netherlands. Each panel is a different year. The x-axis is age and the y-axis is prevalence. What we can see here is 2 distinct features that are questionable for us. The first is that the age pattern between the US and Poland look different than the age pattern of the Netherlands. We also see that the Netherlands estimates in many of the age groups is quite a bit higher than the estimates in US and in Poland, and in some age groups are more than 3 times higher. Here, one of the questions that we'll ask ourselves is if the estimates in the Netherlands or Poland and the United States are correct. They reflect the population epidemiology of psoriasis. Or is this an issue of reporting or sampling or healthcare seeking behaviors that can affect what these estimates look like? And so there's a bias that needs to be corrected for. These types of questions that we'll look at and we'll find when we inquire about the data, and we'll investigate these anomalies. Another example is when we see a misalignment between the disease specificity and then what we report. So in this example, we find many studies that report only dermatitis. And while dermatitis is a parent category within GBD, you can find estimates of dermatitis. It is actually not a disease grouping that we model specifically. What we model are 3 subcauses of dermatitis: atopic, contact, and seborrheic. What happens then is that those studies that just talk about dermatitis cannot be used in the subcause models without additional assumptions. While we could make an estimate for dermatitis and model that as a specifically separate model, this adds complexity to the modeling strategy for this grouping and requires more resources. So what we've done is we made the choice to model the subcause specificity, and then we document this gap. Now, the nice thing about the iterative nature of GBD is that it gives us the power and the flexibility that we can undo this if we choose to. And so part of the discussion that we're always having with our experts is to be able to debate the choices that we've had to make, the challenges that we observe, and then think about what the future plan could or should be for each individual disease area to properly reflect the data and the epidemiology as best as possible. When we have all this information and we've made these choices, we then know that we will have data across different measures. So for right now, for skin diseases, we have data on prevalence and on incidence and on mortality, depending on whether or not that disease can kill you. And then we use expert information for duration and remission. These pieces of information must be standardized to ensure that it all describes a common gold standard reference case definition. We will do data processing to adjust for these biases that we can tell when they exist. What we will then do is take that information and we will put it into a statistical tool that can integrate information across multiple measures using a set of equations that force the information to resolve each other. Here we also add covariates, and we leverage a geographic cascade to use information in epidemiologically similar locations to help generate estimates in locations and age groups for which there is no data. When there's data, we want the estimates to follow where there's data. These estimates are then validated through expert critique using country experts, topic experts, and then internally within IHME an iterative review to ensure that the quality of the estimates best reflect the epidemiology that we understand, as well as the data that we have. Here's an example of model behavior from a preliminary atopic dermatitis model in 3 separate locations. On the left is Florida, in the middle is Ghana, and on the right is Beijing. The crosses here represent the data sources we have, and then the blue lines represent the model estimates. What we'll do is we'll evaluate how well the model estimates are fitting the data, what that age pattern looks like, and any geographic variation that exists between countries. This allows us to communicate with our stakeholders in a way, and we'll do this in advance and iteratively to ensure consistency. We are currently in the middle of GBD 2025, and in this round, we've tried to address a few different things. The first is expanding our evidence base. We've included new clinical and claims data sources. We've gone back for Isaac, the survey series, and done an extraction from the individual level data to collapse it. So now we have very granular estimates by age group. We've also adjusted, improved our development bias adjustments. And then we've also integrated efforts from the GATA systematic review. So we've been able to look at the data that has been extracted through the GATA systematic review and any data that we also agree with for our modeling purposes, we've been able to include. We also go back and we audit legacy data. We reassess the extraction quality from prior rounds, and we'll retract those changes. And then we have been having regular monthly meetings with our experts to discuss priors, assumptions, and data validity. And we use this information so that we know that within this cycle, we know what improvements have been made, what improvements we were not able to incorporate, current debates, and that we can revisit this in future subsequent cycles. So because GBD is iterative, as I said, we have a lot of opportunity to always think about the future and how to make our estimates better. And so there's a lot of opportunities for engagement. Here, we're always interested in strengthening our network, expanding our collaborations, and our experts can help us figure out what are priorities within the skin community, what are needs that you all need to help do your job. And so we're always willing to listen to it and think about whether or not the evidence is there and there's resources to be able to manage that. We also want to strengthen the evidence that we are using, and that is through new data sources and data types, getting it from new locations, and really thinking critically about how we've interpreted that data and use it in the model. And then we also really want to use our experts to try to help us understand whether or not we are properly incorporating all the different aspects of the epidemiology of the skin disease in our modeling strategy and make sure that our strategies are as rigorous as possible. We also want to be very transparent with our stakeholders of the choices that we have made. And some of those choices are very practical. They're resource driven, they're time driven. And so that we have an ongoing debate so it's not a secret of why we do what we do and how we've done it. But we also have a plan for the future. So just to summarize, I just want to re-emphasize that GBD estimates are a process, not just a product. These estimates are built rigorously. We have critically thought about many, many dimensions, and I don't want to say that we've thought about every single dimension, but we try. But it is the product of a really thoughtful, critical, structured audit of the evidence and methods and choices. The GBD framework is built for complexity. It is built flexibly as well. So we are able to incorporate new ideas and new evidence as we need. And because GBD is iterative, we can refine it continuously. So each round reflects new evidence, new methods, and new voices. Our partners are a very key part in this because they can help us set agenda for skin diseases. We're always open to new partners because all this insight and information will just help refine our estimates even better. And I've included a link here to join the collaborator network if you're interested in it. Even if you're not, I just wanted to thank you so much. Myself, Liana Ong, and Sunny Lin, who is the researcher working on skin, and Haley Lennox, who manages the team. These are our photos, and then I wanted to also include our email addresses. So even if you choose to not join the Collaborative Network, please feel free to email us and ask us any questions. We're happy to answer. And if we don't know the answer, we'll find out the answer. And if the answer is that we have missed something key, we're happy to update that and fix that for future GBD rounds. Thank you.